Welcome to the Critical Access Hospital Swing Bed Coding and Billing webinar. I'm Jackie King, and I am with ArchProCoding and Consulting. Happy to be presenting to the Indiana Rural Health Association. I am the Vice President of Hospital Education Services here at ArchProCoding, as well as the ICD-11 Readiness Expert. For those of you who may not be familiar with our company, ArchProCoding is an education and membership organization dedicated to providing quality education to our rural healthcare organizations. We are strictly focused on rural, and we actually offer the country's only coding and billing credentials specifically designed for those who serve America's underserved patients, rural health clinics, federally qualified healthcare centers, and critical access hospitals, as well as small rural PPS. So glad to be here with you. If you have questions specific to today's presentation, my email address is on this slide. So feel free to reach out to me. Before we get started, a few disclaimers. The contents of this program are copyrighted by the Association for Rural and Community Health Professional Coding and Consulting, which thankfully we have shortened to ArchProCoding and Consulting, and cannot be used, recreated, reproduced, or disseminated to any other party without our written consent. All rights are reserved. ArchProCoding and Consulting is not responsible for providing billing or legal advice, or for your compliance with federal and state guidelines, including but not limited to the False Claims Act. So basically, you and your organization are responsible for verifying all your code selections and all your billing rules required by your payers. Verify all references and resource materials before following any guidance provided today. And finally, CPT is a registered trademark of the American Medical Association. So use of CPT codes in their descriptions during this program is strictly for educational purposes only. ArchProCoding and Consulting does not claim any ownership or authorship of such contents. All of those rights are reserved by the AMA. So our agenda today is, let's talk about documentation and that physician certification statement. What do you have to have in your swing bed chart to keep your Part A payment from Medicare? Then some ICD-10 coding guidelines when your patient is in your swing bed, critical access hospital swing bed facility coding, and then professional fee evaluation and management coding. And finally, we'll touch on some billing. Okay, so swing bed status, a critical access hospital with swing bed approval increases Medicare patient access to the best, top-notch, post-acute SNF level care. SNF stands for skilled nursing facility level care. I personally can't say enough about how wonderful swing beds are. If you just think about when a patient is in your swing bed, they're up on your acute care floor. That's where they were until they went away from being inpatient, moving over to swing. They're probably, maybe you let them put their street clothes on, but they have that same nursing staffing ratio. They have PTs, OTs, doctors all around them. Just that by itself gives you a higher level of care to your patients than someone off in a nursing home giving a skilled bed who may or may not even have 2 RNs in the entire facility. And I'm not trying to disparage nursing homes. They work hard, they're understaffed, but the best care, in my personal opinion and my professional opinion, is swing beds in a critical access hospital. So there is a statute that requires any patient who's a Medicare patient to have a 3-day, what we call a qualifying stay in any hospital or critical access hospital prior to admission to a swing bed in your hospital or an admission to a SNF, a nursing facility for a swing bed Part A stay or a skilled Part A stay, depending on what they're calling their units. Qualifying stay time doesn't count time in an outpatient. So if you have a patient in observation status, that time doesn't count as an inpatient. They may not feel well, they're in a bed, there's an IV in their arm, and they're in a gown, but they're not an inpatient, they're a Part B outpatient. So keep that in mind when we're talking about giving them moon notices, the Medicare outpatient observation notice, and those types of things. That does not count towards any of the 3-day qualifying stays. These stays can be in more than one hospital, but they must be at least 3 consecutive days. They cannot have been discharged in between. And this Medicare patient swing bed stay must fall within the same, what we call spell of illness, as the qualifying stay. So there's an amazing person that works at your hospital. It could be a social worker, it could be a caseworker. It is the person or the role that allows or accepts patients to your critical access hospital swing bed versus turning them down to a nursing facility for skilled elsewhere. They know a whole lot. They know about what it means and how you're reimbursed and who is appropriately should be in your swing bed and who should not. And we're going to get into that. So that person is pretty smart. They also are going to check for benefit days, all of that. And they know what it means about the spell of illness. And I'm going to kind of explain that high level. The spell of illness means if a person had a 4-day inpatient hospitalization for pneumonia, they sent them home from the hospital, discharged them, and they didn't eat or drink and take their medications. And within 48 hours, they're calling 911 because they're so weak they can't get out of bed. Okay. Now, nothing has happened. They're still recovering from that inpatient stay from the pneumonia. So the person who's accepting them can say, yes, they've had that 3-day qualifying stay for pneumonia and they're still trying to recover. We can place them directly into swing bed or skilled. That's a qualifying stay. Now, if they came home and the next day broke their hip, they would need another 3-day inpatient qualifying stay for that hip fracture to receive follow-up rehab services for inpatient extended care services for that fractured hip. Hopefully that makes sense. All right, when you transfer a patient from inpatient to swing, I mentioned they're probably in the same bed. You let them put some street clothes on. That's awesome. They're starting their recovery. But you have to document this in your medical record. You need discharge orders closing their acute inpatient chapter. You need a discharge summary from their inpatient stay, and you need an H&P for their swing bed stay. Progress notes, orders, everything has to start over with a new chapter, right? And this is regardless of whether they decide to go to a nursing facility and not stay in your hospital. Someone at your hospital is going to do the discharge summary, and someone at the receiving SNF is going to do an H&P. Sometimes we have a little communication error maybe because we don't have a physician says, well, why do I have to do an H&P? I just did a discharge summary. But it's kind of like I explained to our docs, just pretend like they left. Somebody else is responsible. And working where I work, I'm from Illinois, Northwest Illinois. When I first started at a critical access hospital, the person I replaced had sadly and unexpectedly passed away. And we weren't a real busy hospital at the time, so I didn't really have anybody to train me. I was on my own. And a month after I get there, we got surveyed by IDPH. And part of the survey process, of course, is looking at medical records. We were not busy, so our census was like 1 or 2 swing beds. When we got tagged for deficiencies on 4 of our swing bed admissions because we were allowing the transferring facilities discharge summary from a hip or a knee replacement to be placed on the chart with the signature from the attending at our hospital as the H&P, and that was deficient, and we had to do a corrective action plan and all of that. So just sharing what I learned, I would recommend an H&P for your rehab stay, okay? Regardless of whether that patient's staying with you or going somewhere else, someone needs to put that in the chart. Physician certification. This is also required. To meet the requirements to indicate that a patient must have hospital extended care services because their need for skilled care on a continuing basis for whatever he or she was having inpatient services for, we need a physician or a physician extender, depending on your state and your scope of practice laws, to sign this. And on this, it's going to be timed as soon as they admit him over or put him into swing, or what we used to call them swing them, or as soon thereafter as is reasonable and practicable. So of course, if you're thinking about a person being discharged from an inpatient and going off site, it may take a day or 2 for that attending to get in there and do that certification statement. So they're allowing you some grace in there, but get that on there as soon as possible. And that certification is going to give you, I have a slide on the next page that's going to tell you a lot of information, but it's going to give you your medical necessity. Now, there is a requirement that if that patient is in your swing bed for more than 14 days, you need to have some physician recertify their need for extended post-hospital extended inpatient services before that 14th day to allow for that Part A payment to continue on Medicare. And then subsequent certification is required if you're having an interval at up to 30 more days. That's not common in a swing bed, but if it's going to happen, those are your numbers. Nowhere on this certification does it say you must see a patient every single day while they're in your swing bed. No. Medical necessity is the overarching criteria for when a physician does rounds on a swing bed patient. There should not be a hospital policy saying every 3 days we need to see them. We need to see them every day. 14th day, no later, we definitely need to see them, see how they're progressing, and see if they're going to need to stay. And then again at the 30-day mark. But there's nothing in the statutes. This is not a nursing facility, someone living there. This is a person in a Part A skilled stay. Okay, that's the numbers to watch. Here is a sample certification form, and this is from the Colorado Swing Bed Manual. So thank you, Colorado State Office of Rural Health. And I like the wording. So you can use this wording. It can be in a progress note, an H&P, an order, whatever you like. I just really love this wording and feel like it really shows medical necessity. So I certify that Jackie King requires the following post-hospital extended care services: physical and occupational therapy and speech language therapy, whatever, on an inpatient basis because of her need for skilled nursing or rehab services on a daily basis for the following medical conditions: post-acute stay for pneumonia, for which she received inpatient hospital services from, there's your 3-day qualifying stay, from April 1st to April 6th. She is unable to receive these services on an outpatient or an in-home basis for the following reasons. And there's your golden ticket. There's your Willy Wonka candy bar. That tells the payer this patient is unsafe to go home. They are unable to stand without, to assist. Whatever that physician is making his or her determination that they need a skilled stay, that needs to be in there. Okay. Sign and date by the attending. Now, down at the bottom, there's some notes, the timing, the recertification no later than the 14th, and then at intervals not exceeding 30 days apart. And then when you're doing that recert, it can just be a progress note. Tell us why they need medically necessary skilled services to begin to continue them at the swing bed level and not at home, how long you think they're going to need to stay there, and any plans where appropriate for home care. When our physicians are seeing our patients in swing or inpatient, and a lot of times even in OBS, they're looking at discharge planning right away. They're already trying to see how we're going to safely get them discharged at home and recovering. So that's not anything unusual that you're going to have in a note anyway, but those are some tips from Colorado for that. I just really like this document. So feel free to, kind of use those words, but make sure you got your from and through dates, you got your 3-day qualifying stay, and the medical necessity reason why they can't have this in their home or as an outpatient. Okay. Going over to ICD-10 coding. So ICD-10 is the diagnosis coding section of codes that we report on our claims. So I'm going into section 1, swing bed coding for aftercare, under the category of Z codes, which is chapter 21, letter 7, aftercare. Aftercare visit codes cover situations when the initial treatment of disease has been performed and the patient requires continuing care. They're in the healing or recovery process, or they're having long-term consequences of the disease. The aftercare Z code should not be used if treatment is still being directed at a current acute disease, then just use that diagnosis. So say someone's having sepsis, but they're able to be put into rehab and kind of start beefing them up. They're still taking IVs of medication. We're going to put sepsis or the infection or cellulitis or whatever it is as our first listed diagnosis. Now, the aftercare Z codes should also not be used for aftercare for injuries. So aftercare following an injury, of course, you know the rules. You assign the acute injury code with the appropriate 7 character. It's probably going to be a D for subsequent encounter for routine healing for that acute injury. Right? I watch. Okay. Going over to status Z code. So when we code, and when we document as a physician, we are telling the patient's story. Every time we document, we're telling the patient's story. So the better we can assign codes based off that physician or provider's documentation, the better we can tell that patient's story. So let's say a patient's coming in for an encounter for surgical aftercare, having had surgery on the circulatory system. So that is a Z 48.812. But why don't we tell the rest of the story? We know that they had a CABG. We know they had a coronary artery bypass graft, and that's what their surgery was. So let's add a Z95.1, indicating that there is a presence of an autocoronary bypass graft, telling the rest of the story. That's absolutely okay, and that is right in the guidelines. All right, going over to chapter 9. So really, when you're coding these, just read your doctor's documentation, understand the guidelines of the ICD-10, and you got it. So let's go chapter 9. We get a lot of patients coming out of an MI, acute myocardial infarction. The rules say in the guidelines under section 1, for encounters occurring while the myocardial infarction is equal to or less than 4 weeks old, including transfers to another acute setting or a post-acute setting, which is your swing bed, and the myocardial infarction meets the definition for other diagnoses, look under section 3 for reporting additional diagnosis codes. You may use I-21 category to be reporting because you still are considering them as an active MI. Now, if it's an encounter after the 4-week time frame and they're still getting care related to having that MI, then you're going to use an appropriate aftercare ICD-10 code, a Z code. And then you can use the old MI, I-25.2, as telling the rest of the story. We're having aftercare because they had an MI. Going over to chapter 19 in the ICD-10 guidelines, injury, poisoning, and certain other consequences of external causes. What I mentioned earlier about that 7th character. When you're in this section, there are 7 characters that tell the rest of the story. Is this the very first time, or this person is still receiving active treatment for this fracture? Then that's going to be an A or a B, depending on whether it was an open or a closed fracture. But if they're in the routine healing subsequent time frame, they're going to have a D, or potentially if they're not growing, the bone isn't growing together, there may be another character. And then if it's years later and they're having issue, they're having osteoarthritis or pain when it's cold, it's a late effect. It's a sequela, which is the S. So the 7th character, D, generally D, is used for encounters after the patient's completed active treatment. The condition is done, and they're getting routine care for the condition during that healing or treatment phase. The Z codes for aftercare are not for conditions for injury or poisoning. That's where your 7th character comes in. So if it's aftercare following an injury, use the injury code with the D. And then specifically down under this section, going to letter C, it actually calls out coding for traumatic fractures, stating aftercare Z code should not be used for the aftercare of a traumatic fracture. For aftercare of such, you assign the acute fracture code with the appropriate 7th character. Keep that in mind. I was in section 1 here. I'm popping over to section 2, which is the selection of principal diagnosis for rehab. So they're coming in generally to your swing bed, possibly for rehab or for IVs. Letter K, admissions or encounters for rehab. This is coming right out of the book. When the purpose for the admission or encounter is rehab, sequence first the code for the condition for which the service is being performed. So they give you an example. If they're coming in for rehab for right-sided dominant hemiplegia following a CVA, report I-69.351, which is hemiplegia and hemiparesis following a cerebral infarction affecting the right dominant side. That's your first listed or your principal diagnosis. And then if that condition, though, is no longer present, if they lost feeling, but they recovered the feeling in their right dominant hand, and now it's just weak, then you're going to report an aftercare code. And finally, again, for rehab services following active treatment of an injury, assign that injury code and the appropriate 7 character for subsequent encounter as your first encounter. Let the documentation be your guide and follow your guidelines. I do want to bring to your attention a fairly new, it's not even 2 years old yet, ICD-10 code in that chapter 21 for encounter for sepsis aftercare. And that is a Z51.A. When a patient has sepsis, post-acute care and home health care play a huge role in ensuring that continuum of care for sepsis survivors. Because they may not have sepsis anymore, it was kind of an invisible condition before they created this. So we're treating them in a post-acute care, but they don't have that. But we need to tell the payer, hey, this patient is in skilled nursing or a home health care or an inpatient rehab or a long-term care because they're trying to recover from sepsis. And sepsis recovery, is a very lengthy process. So keep this in mind if you've got someone in your swing bed following sepsis, that you tell the story correctly. All right, nursing facility professional services. The guidelines for this is in your CPT manual. Now, CPT is this big, beautiful yellow book written by the AMA, okay? So their guidelines, let me just tell you that the guidelines in this book are not licensed to secondary publishers. I don't work for the AMA or get any money, but if you're a coder or a boss, a manager, you buy this book for your coder or you buy this book for yourself. This is the book. The rest of them, doesn't matter who publishes them, but that one there, that's got all the good stuff, okay? When you're looking in the guidelines, and I could open this up, but you can go follow with me, it states that the principal physician is sometimes called the admitting or the attending, and that's the person who's overseeing their care. We could have a patient coming in for an initial swing bed visit and also have a consulting doc come in, but we can't build consultation codes for Medicare. So there's some modifier information that we can put on a claim if we need to bill for the attending or the admitting and a consulting on the same day, because we're using the same set of codes. So how do we tell the payer's story or tell the payer the patient's story? Modifier AI, which is an old modifier, is indicating that this line item for this E&M code is our attending. So we will put an AI on their visit code, and anybody else who does an initial evaluation is just going to bill an E&M code without it. The AI modifier is for principal physician of record on an initial hospital and an initial nursing home visit code. And here is a Novitas modifier AI fact sheet that you can kind of peek at to read through this if you've never heard of it, because it's kind of an old one. So it does say the appropriate use is admitting physician to an inpatient hospital or admitting physician to an initial nursing facility. It gives you your CPT codes. Okay. All right. More guidelines. When you're selecting a level of medical decision-making, if I might, I'm looking for a tool here, but I laid my book on top of it. Here we go. Medical decision-making. Okay. For your nursing facility services, the number and complexity of problems addressed at the encounter is considered. So when you're looking at this, and I have it on a different slide, medical decision-making has three columns. The first column is number and complexity of problems addressed. The center column is the amount and or complexity of data to be reviewed and analyzed by the physician or provider. And the final column is risk of complications and or morbidity or mortality of patient management. So if you're looking at mine, you see there's a big space down here. When you are doing an initial nursing facility E&M only, you can add this in a different color, multiple morbidities requiring intensive management. This is a set of conditions or syndromes or functional impairments that are likely to require frequent medication changes or other treatment changes or reevaluations. The patient is at significant risk of worsening medical, and that includes behavioral status, and at risk for admission or readmission to a hospital. That's why they're in your swing bed. That's why they can't have this at home or at an outpatient. This is one out of the two that you need to get a high level of medical decision-making on your initial CPT E&M code, okay? And it's intentionally not there because we don't want anybody using this for other categories of evaluation and management codes. So this is what I just held up for you, and you see the little blank here. And then we have this right here, a different color. Only for initial nursing facility can you use that. So I've just put it in a different color, okay? And when we go through this, I'm going to go backwards just a bit and kind of talk about E&M just briefly. Let's go through this real quick for you if you are not familiar with evaluation and management. So here it does say based on 2 out of 3 elements. So 2 out of 3 elements, you've got straightforward, low, moderate, and high medical decision-making on this. So it kind of goes through the possible problems and complexity that could be addressed here. The red font, in January of 2023, they added red font to this. This is the most recent version I have. So there's your kind of problems that they could be addressing. And down here is going to have your multiple morbidities. All right, second column. There are straightforward is really no data or limited data could be. There's 2 categories in there. There's category 1, which includes tests, reviewing of tests or ordering tests and documents. And those would be any combination of 2 from reviewing each outside note or each unique test, reviewing and ordering. And here's a tip. If they review and order a test in the same encounter, that counts as 1. So if you get 2 of those, if you get 2 of these, you have a category 1, you have limited medical decision-making. If you have assessment requiring an independent historian, meaning the physician or the caregiver, the provider, needs someone else to tell the story of this patient. Why are they here? Maybe they need a spouse, maybe they need a caregiver to understand what's going on in this patient's health status. And they need that because maybe the patient is cognitively unable to tell them. So that would be where the doctor would mention that they had an independent historian help them with their assessment. Right there, just that gives you at least one of the 2 categories, and you have a low. Now, if we go down to the moderate, just erase my slide, erase my ink, excuse me. Moderate, you'll see there's 3 categories now. You need to meet 1 out of 3. Category 1 is your tests, your documents, and they move the independent historian into that grouping. So 3 prior notes, 1 prior note, 1 order, 1 assessment requiring independent historian. You get it? Mix or match it, okay? Category 2 is independent interpretation of a test. And that means the physician independently states, I independently reviewed this EKG and here are my findings. I independently reviewed these labs and here's what I'm seeing. Not a lab, can't do it under a lab. You can do it under a PAT. It is a test that has someone else doing the interp that you're billing for. There's a CPT code for it. So I independently reviewed this chest x-ray. Don't spit back what you've read from an interpretation from a radiologist. We really need the words, I independently reviewed this test and here's my findings, not what I read off of an interp from another doctor. That is one out of three categories. And then the third category is discussion of management or test interpretation with an outside provider. Okay. So let's say we have a patient who may be cognitively unable to speak, and we want to get a hold of their primary care physician because they're very agitated and we need to know, is this baseline or is this patient in pain and can't tell me? That would be discussion of management with a outside physician with the patient's primary care, and that would count as moderate level of medical decision making. Now, the only difference between moderate and extensive is when you get down here, you have to have 2 out of these 3, and here you only need 1. Then you get over to your risk of complications of morbidity and or mortality of patient management. Very plainly here, anytime you're managing prescription drugs, that's kind of a moderate medical decision making. You're probably not giving drug therapy requiring intensive monitoring, but you might be as a swing bed getting skilled care. That might constitute your high level. Probably not doing surgery or major surgery, but maybe you are, but that's kind of going to take them out of being in a skilled rehab section and putting back into acute. Do not resuscitate or to de-escalate. If a physician and a patient make a decision while they're in a swing bed to go no more curative, I just want hospice, that is a high level of a risk for mortality. So that is high, okay? So keep that in mind. And then parenteral controlled substance would be any controlled substance like Demerol, or any of those pain meds that you're giving any other way but in the mouth, okay? All right, so that, I just wanted to go over that. And this is the, let me hit the escape button and get that out of there. Whoops, I got to erase my ink. Okay, this is where I pulled this up. You can pull this off of the web. Okay, going back over, remember your nursing facility only, and moving into actual CPT code descriptors in our yellow book. A 99304 says it's an initial nursing facility E&M for a patient, which requires a medically appropriate history and or exam. Folks, it does say one or the other, but I have yet to see a doctor's note without both. And then it has straightforward or low level of medical decision making. So let me go back to my highlighter. So they took straightforward and low and mushed it together into this 99304. Then this is moderate medical decision making and this is high. Now, when you're using total time on the date of the encounter, remember, it's everything the physician does for that patient on the date of the encounter, not that face-to-face time, 50% spent counseling. That's gone. That's gone. Okay. Everything we did for this patient the entire day gets added up. And this is a minimum CPT code. There are midpoint CPT codes too, but these are minimum. You must meet or exceed the number in the book to be able to report based off of time. So even if I have 49 minutes spent all day today caring for the patient, I only have a 99305. I must meet or exceed 50 minutes. Be careful with that. There's a 99418, which is a prolonged services code. In your CPT manual, right below code 99306, it says for number of minutes, 65 or longer, report 99418. I want you to go in your book, and I want you to write G0317 for Medicare right next to that parenthetical note, because Medicare won't allow a 99418. They have their own set of codes. Okay, so do that in your book, and then let's erase my slide and move on to the next slide. Oh, here's a tip. This is on page 29 in your CPT book. Look at the third paragraph down in the first column. Initial nursing facility care, and it says new or established patients. Hospital inpatient or observation discharge services performed on the same date of a nursing facility admission or readmission may be reported separately, and Medicare will pay for both. So as you're having that conversation with your provider saying, thank you for the discharge summary, I now need a history and physical for today for the follow-up for the swing bed stay. By the way, you can get paid for both. That might help your cause too, okay? But we need 2 notes, All right, when you're looking at subsequent nursing facility care, you'll see there's a star on this code. And I didn't really go over the symbols, but I'm gonna just kind of show you. This star, where's my highlighter? Right here, says per the AMA, per the CPT book, A physician could do a subsequent nursing facility encounter, evaluation, and management on a patient using two-way audio, video, telemedicine technology. That is the CPT book. You have to check your payer. Okay, don't assume because CPT says it's golden that your payer will say that. There are a lot of codes in that CPT book that will never get paid. So be careful with that. Double check your payer, okay? When you're using, so it still has the evaluation and management of a patient, which requires a medically appropriate history and or exam. This one has straightforward all by itself. 99307 is by itself. This is low medical decision making, moderate, high, and then your prolonged service code's listed down here. But remember, G0317. So in your CPT manual, because you got to flip the page, when you're looking at that parenthetical note, make sure next to it you put, next to that 99418, you put G0317 for Medicare. So you don't accidentally bill the wrong thing. And the time is much lower. You don't have to meet the time is high because you kind of know the patient already. Okay. All right, this is the actual 99418 CPT code descriptor. I'm just going to buzz through. This little hashtag means if you went in numeric order, you're not going to find it between the right. It won't be in numeric order. It means it's out of order. Go to Appendix N, that's your friend. That's where you find things. The star again is saying the CPT book says you can use prolonged service E&M add-on codes with two-way telemedicine, audio, video technology, but you got to check with your payer. That's me talking. And then the plus sign means this is an add-on code. It means you can't build this without the parent code. When you're looking in your E&M chapter, all of the higher level E&Ms will always have that parenthetical note. It will tell you, like, use this with in conjunction with these E&M codes. But it'll also say, do not report for any time unit less than 15 minutes. And that's very important. These are also minimum codes. They're not midpoint. So don't do that. Now here's your CMS prolonged service one more time. G0317 is what you're going to report on each 15 minutes. So you can do up to 4. I checked medically unlikely edit on these. You could bill up to 1 hour. If you have a full 15-minute increments of time, adding on with that G0317 to a Medicare patient, if it's taking them that long for the E&M while they're in there. All right, this is the set of CMS prolonged service codes. So CMS is the largest health insurance company in the world, and it is a taxpayer-funded healthcare insurance policy. So they are judicious and they watch utilization. And that's why there's this book, the HCPCS Level 2 book. This book was created by Medicare as a supplement to our Pretty Yellow book so that they could break apart and look at utilization and expenditures at a more specific CMS beneficiary level than in the big yellow book. So here's what I have. G0316 is if you do a prolonged service hospital or observation E&M. Your G0317 is what we're talking about, a nursing facility. And remember, when a patient is in your critical access hospital swing bed, you are using nursing facility E&M codes. Do not use inpatient E&M codes, okay? And the G0318 is home or residence E&M codes. All right. Now, discharge services. When you're reading the guidelines of your nursing facility discharge services, that's everything that patient did, preparing that patient for final nursing facility discharge. And it's a lot of work. They include, as appropriate, time spent in final examination of the patient, discussion of the nursing facility stay, and instructions are given for continuing care to all your relevant caregivers. They're preparing discharge records, the discharge summary, prescriptions, referral forms, orders. Time for this service includes the total time spent on that date, even if they're not in the room with the patient or their family that whole time. And these discharge services require a face-to-face encounter with the patient that may be performed the day before they go home. This may not match the date of discharge. Code selection is based on the day of the face-to-face encounter, it may not be the day of discharge in this scenario. This is a nursing facility, okay? 99315, nursing facility discharge management, 30 minutes or less on the time of the encounter, on the day of the encounter. If you ask a doctor, how long does it take you all day long to get a patient ready to go home from swing with, doing the orders, talking to them, seeing them, examining them, doing your discharge summary, half hour or less, they're going to laugh at you. Ha! Takes me an hour at least. And that's when you come back and say, well, Dr. Smith, if you don't write it down, I can't bill for your time. So I need to know how much time you spent. So a 99316 tells the coder, tells the payer it was more than half an hour, more than 30 minutes. I would love to see all of your discharge services with a total time spent. I don't love greater than 30 minutes. That's almost leading, but if that's what you choose to do, that's your policy. But total time spent so you can get your doctor what they need. There's no add-on codes. There's nothing prolonged. You either have 30 minutes or less, which is a low E&M, or greater than 30 minutes. And I can guarantee it's a lot of work and they're spending more than half an hour. Okay. So do a little audit, a little quiz. Go back, check if you're a biller or if you're a coder, and do a survey, run some accounts. 30 charts is a statistically valid sample. Check your 99315s. I'll bet you 25 cents that not one of them has total time. And that's why you had to default to the lowest code, and then go check your 99316s. There better be documentation of a time higher than 30 minutes or you overbill. Really good eye-opening experience, very different payment. Doctors deserve to get paid for their time. This is a really great idea, even a hard stop. I know we don't like hard stops, but that's a way to get your revenue that you have coming. Let's do a coding example. Patient with severe degenerative osteoarthritis for the right hip underwent elective hip replacement, and the current encounter is for rehab. So how are we going to code that? Well, let's see. It was elective. They had arthritis and had a hip replacement. So I have aftercare following joint replacement surgery, a Z47.1, as my first listed, no trauma. Now a patient's getting that hip replaced for a displaced right intertrochanteric femur fracture. Now I'm going to report my injury code, S72.141, displaced intertrochanteric fracture of the right femur with a D, subsequent encounter for closed fracture with routine healing as my first listed. No, this was not an elective surgery. There was trauma. There was an injury. I highly recommend you check into your CMS fact sheets. There's a fact sheet out there for CMS swing bed services, and anything in red font is new. So you can take and check on these at your leisure. And there is one for critical access hospital that's very new. And it actually, if you go and search this, you can get to swing bed. Well, if you spell the word swing, you'll be in great shape. So it takes you down and it talks about swing bed as well. So lots of information for your swing bed in both of those fact sheets. I'm going to go over the 4 parts of Medicare because we're going to talk billing as well. Medicare Part A does cover your swing bed, hospital, inpatient, skilled nursing, hospice, home care. Beneficiaries receive Part A if they or their spouse paid into the Medicare program while working. Part A benefits don't have a monthly premium. They were paid while working from the beneficiary, but there's an annual deductible due every 90 days, known as a benefit period during an inpatient stay. A swing bed is an inpatient Part A stay. The 2026 Part A inpatient deductible that could be due every four benefit periods is $1,736. So I'm just going to show you where you can find that. Every year about mid-November, they come out with that. So really, if a person had 4 benefit periods in a year, it'd be very unfortunate. They would have just for deductible, yes, $6,500 just for Part A. So we try to keep them healthy and outpatient in the world. Speaking of outpatient, Medicare Part B covers outpatient. There is truly an annual deductible. It's $283, but there are co-insurance amounts that will be due from the patient in addition, where there is no such thing for Part A. Again, outpatient services, doctor visits. When you send your bill from a critical access hospital, they're going to know your critical access based off your bill type of an 085X versus a PPS. Kind of interesting. You have your own bill type. A beneficiary can have Part B benefits if they choose to pay a monthly premium. The premium will change. I told you that link. You can go on previous slide. Every year it changes. And Medicare may pick a Part A and not Part B if they choose not to pay the premium. And that's why a copy of the card or that online eligibility is uber important. If they come into your swing bed unit for Part A and they have it, but they have physicians seeing the patient, those are self-pay. Those are uninsured visits. There is no insurance coverage for when the doctor does his or her H&P or any progress notes of the discharge summary. So your billers or your patient financial advocates need to start having conversations with that patient about help paying for your uninsured, uncovered Part B related services. And there are some Part B services for full coverage for preventive. And this is just, this is cool. So this is the preventive services website. We'll keep going, but I like to give you things. All right, there is another part of Medicare of the 4 parts, and it's Medicare Part C, and that is the Medicare Advantage plans. Now, an eligible patient can choose to enroll in an MA plan, which is a commercial, a private insurance company adjudicating Medicare claims. The coinsurance, the deductibles vary by plan. They're very attractive. As of 2025, 53% of our Medicare beneficiaries elected a Medicare Advantage plan. I feel that may go down for 2026. There was a few plans that had to close, so we may have it more as a 50-50, but we need to be aware that this is out there. And they are required to pay a minimum of traditional Medicare payments for coveraging, but they can cover more. They can do reduced cost sharing. They can pay for dental that Medicare doesn't pay for. So they're very attractive, okay? Only the patients eligible for Part A and B can enroll in a Medicare Part C plan. This is not a marketplace insurance. They have to be a Medicare patient, a Medicare eligible beneficiary. Most billing guidelines are going to apply from your hospital to a Medicare Advantage plan, but you need to be familiar with each plan that you have contract with and their billing requirements, because we're seeing more and more plans with stricter regulations, maybe in the area of pre-authorizations or bundling of charges or procedures. Don't just assume they're going to cover it like traditional Medicare, because they're not. Okay, you have a contract. You need to have that contract in front of you so that you understand what's covered and what's not, and how that cost sharing is going to fall onto that patient, because we need to advocate for our patients. By the way, I'm a patient. You're a patient. We're all patients, right? All right, so let's advocate for our patients. We do send our claims out on a critical access bill type, and they should understand that you're billing under critical access and be reimbursing you cost-based reimbursement accordingly. So when you are doing a rate letter, so your critical access, you're paid 101% of cost for your swing beds and your inpatients. And then you send in your cost report, and your MAC, your Medicare Administrative Contractor, sends you back a rate letter every time you do that. On your rate letter does have your per diem amounts, your per day amounts. Make sure you load that and get that to any MA plan that you are contracted with. And even if you get somebody who came in and now you aren't contracted with, get it over to them so that they can pay your facility correctly. Finally, Medicare Part D is the drug coverage. They have to be eligible for Part A, enrolled and paying a premium for Part B. And both traditional Medicare Part D supplements and Medicare Advantage are private entities. So you will see that they can design different benefits, and including formularies of what drugs covered at what tier. And this could be an area where if a patient is on a drug for the rest of their lives and it's covered way better in an MA Part D plan, they may elect Medicare Advantage for that. For any patient, MA or regular Medicare, for 2026, there's a $2,100 cap on covered Part D drugs. If the patient has a deductible, they'll meet that, and it's no more than like $600. And after that, they'll not spend more than $2,100 on Part B drugs. That's a wonderful thing for our patients, okay? There are a cap on what you're going to pay by the plan, and this is just an outward-facing Medicare.gov website that explains this. So if you're a patient financial advocate or a social worker, this is where the patients should go to find their information, and it talks about how drugs are covered. It says, here's the deductible stage, here's what a copayment means, and here's what coinsurance, and then it talks about the 3 stages of coverage. So very interesting tools that you can work with to work with your patients. Cost reporting is, of course, we are required to file an annual cost report. Anyone who bills Medicare files a cost report, okay? It's very important that ours is correct, because we are paid based off our cost report. So every time we send it in to Novitas, Noridian, CGS, NGS, WPS, they're going to come back with us with a rate letter. And every hospital is going to be different, and any cost reporting is going to be different. Like every time it'll be different. So you get your rate letter annually, no more than annually. You're going to do it at least once a year. Here's what's on that. Your inpatient per day, or per diem, we call it. Your swing bed per day, if you have a swing bed, and your percent of outpatient charge to be paid. Again, remember to shove this over and let your Part A, or your Part C Medicare Advantage plans get that over to them. And if you have a per diem amount, unless you're contracted with them differently, that's what they should be paying you. Now, again, I was saying per diem. Per diem is Latin for per day. So we talk about the inpatient per diem and the swing bed per diem. Now, the inpatient's going to be a higher rate because they're more acutely ill, and it's going to cost more to care for them than the outpatient cost to charge, or the swing bed. That's going to be lower. So swing bed reimbursement, our wonderful, beautiful SNF level services that are fabulous, provided by our CAH at our swing bed, are getting paid at 101% of reasonable cost. That's fabulous reimbursement. That's awesome reimbursement. Coinsurance and deductible are applicable for inpatient. So there's really no coinsurance. It's going to be deductible. Okay, coinsurance would be Part B. And there's your claims processing manual, chapter 3, section 30.1.2. You're able to look that up yourself, so I'm not going to go there. All right, this is important. When you are billing on a swing bed, any facility services, not your doctors, any facility services that you're doing for a patient in a Part A swing bed, okay, they have to go on your swing bed bill. Why? Because critical access hospital swing bed services are subject to the hospital bundling requirements of the Social Security Act and the Code of Federal Regulations. And therefore, any non-doctor, non-professional services provided to a patient while they're in your swing bed have to be put on your swing bed bill. This is the verbiage from the policy manual. You can pay bill for bed and board, such nursing services or other use of hospital facilities. Whoops, sorry. That was supposed to be my highlighter. Here we go. Related to hospital social services as are ordinarily furnished by the hospital for the care and treatment of inpatients. And such drugs, biological supplies, appliances, and equipment for use in the hospital as are ordinarily furnished by such hospital for the care and treatment of inpatients. Seeing a trend here? All right. Such other diagnostic, lab, x-ray, MRI, or therapeutic, endoscopy, surgical items or services furnished by the hospital or by others under arrangements made with them by the hospital, ordinarily furnished to inpatients, either by your hospital or by another hospital under arrangements that's going on your swing bed bill, your 181, where you're putting on your critical access hospital provider type. So let's just think about this for a minute. This means if you have a patient in a Part A swing bed stay and they have to have an endoscopy, the endoscopy goes on your swing bed bill. And you do not create a Part B facility claim ever during a Part A swing bed. And it's happening, so I'm really stressing this because I don't want you to have to pay your money back. And a patient should know any 20% coinsurance on any facility Part B charges in a Part A stay. We would never do that for our hospital inpatients. We will never do that for our swing beds. It's the exact same. The bill's going to look exactly the same. It's just going to be a different bill type and a couple different numbers. But that, if that helps you keep that straight, that's what you do. This is the source of the information. Section 60 should be page 8 still. See if we can get down to page 8. 8. So here you go. CAHs are exempt from the SNF prospective payment system and instead are based on 101% of reasonable cost for swing beds. We are subject to hospital bundling requirements for both the CFR and the Social Security Act. Therefore, all services provided to a CAH swing bed patient must be on the CAH swing bed bill. Okay? Very important that we keep that in mind. All right. I'm going to move over to the next slide and talk about billing. Our services are billed separately from inpatient. It's a bill type, a different bill type. We submit one NPI when we're billing for our swing bed, and it's going to have the NPI and it'll map it over to your Z code, your CCN number. Again, we're exempt from the SNF prospective payment system. So are paid instead 101% of reasonable cost. So if you look at the SNF PPS, it's different. This is why your person that allows a patient into your facility versus not, they know this. So they're not probably going to have a patient who requires dialysis, routine dialysis in your swing bed because your hospital will have to pay the dialysis bill and put that on your swing bed claim. And you don't get any extra. You get the same flat rate. So you're outlaying all that money. You're not getting anything right away. Sooner or later, you're going to get a higher rate. But until the next cost reporting period, you're forking out all the money. If a patient needs to go, let's say you have a patient who's had a knee replacement. 4th day into their stay, they spike a fever, and now there is redness and swelling in the joint replacement incision. So they call the orthopedic doctor, and she wants an MRI of that knee joint, and you don't have an MRI. So you now have to package that patient into the ambulance, take them to a tertiary hospital, get an MRI, and bring them back. And all of that, the EMS and the MRI goes on your swing bed bill, and you got to pay for that. So that's why people are really careful. That can happen, and that will eventually raise up. But just know they can't bill. A SNF PPS, they are getting a much lower rate per day. And if someone needs dialysis, dialysis can bill directly to Medicare. They can just go off and bill that. That's not falling under the nursing home. That's different. Your hospital bundling, it comes on your bill. So be very careful. Okay. That's just, I can't stress that enough. I've seen people do that. So here's again your claims processing manual. Just a quick touch. If you are a hospital with what we call CRNA pass-through exemption, CRNA pass-through is where we don't have a real busy operating room. So they're allowing us some cost-based reimbursement. It's not method 2. It's cost-based reimbursement to allow us to do some operative procedures in our ER, in our OR. So if you have CRNA pass-through and you do an endoscopy or anything that needs the anesthesia provider to assist the surgeon or the GI doc, those charges will both go on your swing bed claim, because pass-through exemption is considered a facility reimbursement process or facility reimbursement policy. So your revenue code for your doctor, as well as your revenue code for your facility, both of those are going on your swing bed bill, because that is considered a facility coverage, okay? QZ modifier may or may not apply if you are a CRNA pass-through. Here's where you can look up all that fun information, especially if you can't sleep tonight. All right, just wanted to touch on that. Reimbursement for a swing. Remember, you're getting a Part A flat reimbursement per day, regardless of what you do, procedures, anything you do in your hospital is going on your bill, but you're getting a flat rate. And again, it's probably going to change every year for each cost reporting period. And sometimes you may file a cost report more than once a year. And we would call that an interim cost report. And you'll do that because you want to make your costs and your expenses match as closely as possible. So if you had a huge capital expenditure and 2 months into your next cost reporting period, you paid it off, your costs went from way up here down here, but you're still getting reimbursed high. If you don't change that, you're going to owe money to Medicare at the end of your cost reporting period. Also, if you have a huge something happened and there was a pandemic, a public health emergency, you're putting all these agency nurses in there, you're building walls, personal protective, so your costs went way up high and you're not getting very much, you may file an interim to get your payment to match so you're not struggling and you're getting your payment as you need it. And a Part A inpatient deductible is due every 90 days, same as PPS. And under our reimbursement, there is no outlier payment. So regardless of charges or procedures, every day is the same amount until you get your new cost report. And keep in mind, a patient day is counted at midnight, starting on the day of admission. So there is no reimbursement for the day of discharge, except if they're admitted and discharged on the same day. So we always are working with our discharge planning rounds, mainly because we want to know if they can get home safely, but also on the day of discharge, out the door, okay? Because everything you do that day is free to you, free to the patient. You get nothing. I'm going to talk real quick about shadow billing. When you have a patient in your hospital for inpatient or a swing bed, you are going to send a shadow bill, a ghost claim. I don't know what you call it, but it's automatically generating a claim out of your billing system over to traditional Medicare. And it's for them to be able to track days, utilization, EHR payments. There's a lot of different things that Medicare traditional is doing behind the scenes. It's still a Medicare patient. Okay, so they're watching that. The bill's going to go out on a 111 or a 181 bill, depending on whether it's an inpatient or swing. It'll be a condition code 04 saying this is an informational only bill. Medicare is your primary payer. There's no Medicare secondary payer questionnaire, which is required if we're billing Medicare for anything or not. Okay. And you need the Medicare beneficiary's MBI number. You need the Medicare number. That's why a lot of times when you admit a patient for a Medicare Advantage, you do get and look up their Medicare number too, because those shadow claims are going to go out and that has to go on. And it's not the same as your Humana number. Okay. So lots of information on this slide. Here is what a shadow claim, kind of a claim example, goes out. You'll see all these field locators. You'll see that this is saying it's an informational only bill. It's got the date, it's got some revenue codes and some money, so they can calculate that. This is where I pulled this information, so you can look it up and take your time and read through it. There's inpatient or swing bed. Okay, if you didn't know that, that's something new. I learned that way back when I first worked at a critical access hospital. This is a sample outpatient. They call it a UB or a facility claim, or sometimes CMS calls it a 1450. How confusing is that? Sorry, but this is a sample outpatient and this is a sample inpatient. These are what the claims look like. Now, actually, when you're doing your work in your encoder software, it's creating an electronic claim. But when you're teaching a biller, or if you're trying to understand even as a coder or someone who's working a denial or a rejection, it's very helpful to understand what each of the field locators mean on these claims. I'm a visual person. That's why this is AmeriHealth. This is an actual payer. This is not ArchProCoding. Thank you, AmeriHealth. I love this tool. Each field locator is listed. What is it? Is it required on inpatient, which would be your part A, swing bed stay, or outpatient, which would be your part B? It's so cool. And then actually here are the claims. And you can see the field locators again. Here's your 1, here's your 38, 42, okay? Just something really good for helping billers or anyone who's working with rejections or denials to understand what we're talking about. This is a 1500 claim form. Also, this other claim is called the 837I or the institutional claim. That's the electronic format. This is called the 837P for professional. And this is where you can find this claim form. Same deal. Blow it up. Here's all your field locators, 1, 1A, 12, 17. And here is instructions for working this paper claim form. Again, here's your field locator. Is it a required field or not? And the description. Just some tips that I found to help you understand billing and work through it if you're dealing with rejections or denials. So let's go into the rejections. So when a electronic claim is received by a payer, its information is matched with what the payer has on file. And if any information doesn't align, the claim's just it's going to be rejected from processing. So many of these can just be fixed and then it can be generally resubmitted. So you're going to need to know what the process is by payer. So here's some common errors. Maybe a wrong member ID number or an incorrect payer ID or the patient's date of birth or misspelled name or their sex, male, female could be wrong, bad address. Diagnosis billing information, you can have an outdated or an invalid ICD-10 code. You could be missing a 7th character, an invalid CPT code if they deleted it and it's the new year and you didn't update your charge master, maybe a wrong or a missing modifier. And if your own billing information was incorrectly entered or isn't up to date with that payer, that can result in rejection. So that would be using a wrong taxonomy code or a billing address or tax ID or rendering NPI or billing NPI that hasn't been on file with the payer. So lots of work with rejections. They take a lot of work, but denials take even more work because the denial says the payer has accepted the claim and they're not paying you. You can't just resubmit those. You have to appeal and send reconsideration requests or redeterminations. That means a lot of work for your billers, okay? And in a critical access hospital, your billers are probably also your denials and appeals people. So it's a big job. Maybe they say you're trying to unbundle. We've already paid you during this span of dates for this claim. We're not paying you, and then you got to look through that. Maybe they're going to say it's not covered and we didn't check eligibility, or maybe we did and we have to fight back and prove it. Timely filing has expired. Each payer has a set number of days following a service for a claim to be reported. If it's outside of that time frame, the claim can be denied. So including in this time frame is time to work rejections. You get 365 days for Medicare. Quickest way to resolve a denial is to often just get a hold of the payer directly and say, give me some instructions. Codes that come back with denials or on your claim remittance advices. A CARC code is a claim adjustment reason code. It tells you the main reason for the payment difference. Like this wasn't covered. It's telling you the adjustment. Is it a contractual obligation? Is it falling into the patient responsibility bucket? So here are some common CARC codes. It's under a capitation agreement or managed care plan. It's already bundled for another service, or it is not covered. And then we have a RARC set of codes, and that's remittance advice remark codes, and then adds a little bit more why or what to do next. So check this policy link, or you're missing a modifier. And they are codes that give you some more context, to give you specific instructions. So common RARC codes, you're missing or an incomplete or invalid HCPCS or CPT code, missing or invalid provider ID, incorrect claim form or format submitted, or a duplicate claim. So those are your RARC codes. There are a ton of very awesome billing reference guides here, and I encourage you to check a lot of these out. I'm not going to open them up. You guys are able to open links. Great tools. And then more great tools. So your E&M guidelines, your benefit policy manual for skilled care, your inpatient hospital billing claims processing manual, which I've referred to several times, a swing bed billing guide specific to Noridian, but I don't know if that's your MAC, but you can take a peek at it. The state operations manual, where you are surveyed against, swing bed providers, the CMS site, and then your guidelines for ICD-10 coding and reporting for the current year, which goes October 1st to September 30th of this year. All right, so this is the end of the slides. We do have a website. I encourage you to visit our website. Talk with your folks at IRHA. We do a lot of work with Joyce at the State Office of Rural Health as well for SHIP funds, and the IRHA are managing your Flex grant funds. So lots of opportunities to maybe provide you some extra training. If you're needing it, I'm seeing a question. 340B services for swing bed would be something that I don't, I'm not understanding that quite enough to be able to talk about this during this, because 340B isn't just for swing. So I did not cover 340B in this with 1 hour to talk. No 340B coverage, but if you'd like to reach out to me offline, I would be happy to try to work with you on that question, because we have reached the end of our 1 hour. So I would, I think there's no more, I don't know. I'm looking at my question, but it looks like there's something in the chat box, but unless, open, answered. Okay, I think that's it. So, not seeing any other questions. Thank you very much. Is there another poll that we need to launch at
Yes,
all?
we have another 2-question poll at the end while we're waiting to see if there are any more questions.
Okay. So please do answer those, because as Carolyn referred to, this is the way that IRHA or the state offices can show to the government that we need to continue to get this informational funding, or this funding, to give all this education out to our hospitals so that we can be financially viable and properly keep our doors open, because we're all about keeping your doors open. That's what I'm about. That's my passion. I live and have grown up in rural, and I still want my hospital there when I need it. So I'm very, very passionate about rural. Looks like we're getting them. I'm not going to answer because I'm not the polling person. All right, that is all I have, and I'm not seeing any more questions in the chat box. So, Carolyn, did you have any final comments from the RHA?
No, I do not. I just want to thank everybody for joining us today. And
Okay,
everybody have a great day.
enjoy it. Hope you had a good lunch while we talked. Thank you.